All right, good evening, everyone. My name is Asti Jackson. I'm a medical science liaison with Myriad Genetics, the makers of the GeneSight test, and I will be your moderator this evening. So before we start, I want to make sure you all know that you should feel free to ask any and all questions you may have. We will do our best to try to address all the questions that we can during this time. If we aren't able to answer the questions during the webinar, we will follow up with you to make sure to get you the answers that you need. To ask any questions, you can use the Q&A feature, not the chat. You have the option to ask the question anonymously, so please ask your question. We will do our best to answer them. And thank you so much for joining us tonight. And so now that I have your attention, so we're here to discuss how to address concerns with genetic testing across communities of color. And so we know the salience of race and historic healthcare injustices in the United States likely acts as a barrier for people of color to participate in genetic testing. For example, studies suggest that the Tuskegee study of untreated syphilis frequently functions as a historical reference for the distrust of medical institutions and research among African Americans. Also, personal experiences with racism among people of color and witnessing expanding health disparities in spite of medical advancements may also add to beliefs that the medical and research communities are not trustworthy. And more specific to genetics, revelations about Henrietta Lacks, who was an African-American woman whose cells were taken without her consent and used for research, raises concerns and about trust, privacy, and the benefits of genetic tests and studies amongst people of color. Even though there are concerns, real concerns about genetic testing amongst people of color, with this in mind, we wanted to have a conversation tonight about how genetic tests such as GeneSight may benefit patients, especially people of color, how healthcare providers navigate these conversations around genetic testing with their patients, and discuss Myriad's commitment to privacy and affordability of the GeneSight test, and discuss some clinical data with GeneSight that specifically looks at Black and Hispanic adults compared to overall results. So first, I want to get started by introducing our esteemed panelists. We're going to start with Dr. Bernie Ranchero, who is the Medical Director of Leadwell Division of the Hospital Sisters Health System in Charleston, Illinois. Thank you so much for joining us, Dr. Ranchero.
Thank you.
Thank you. And next, we have Dr. Gus Alva here. He is the founder and medical director of ATP Clinical Research in Costa Mesa, California. Dr. Alva is a true visionary in various treatment methods for mental health disorders, and we are so happy that he includes GeneSight in his toolbox. Welcome back, Dr. Alva. And we also have here Dr. Angela Shannon, who is the medical director and founder of the Positive Balance Wellness Center in Atlanta, Georgia. Dr. Shannon has truly expanded how mental health is viewed in her community, opening a mental health clinic in her church. We are grateful to have you back for this webinar.
Thanks for having me. Glad to be here.
Thank you. So let us just start there. So we wanted to tackle this topic as we know that there's a lot of mistrust in communities of color around the medical profession, and especially genetics. And one of the top questions patients ask about GeneSight is, what will they do with my DNA? And it is important for providers and patients to know that GeneSight has rigorous policies around privacy and what happens with patient samples. And some of these policies include destroying all samples within 60 days and removing all identifiers from samples. With that being said, we're going to jump into the panel's discussion. And so the first question is for Dr. Shannon. So how do you address these concerns about GeneSight testing privacy with your patients of color? And are there other genetic tests that you use that patients are more comfortable with using?
Well, first, I start with being very open and honest with them and making sure that they know that I'm not minimizing their air of mistrust. And I mentioned things like, the Tuskegee experiment and, share with them that, your skepticism towards maybe trying this is well placed. However, my experience with GeneSight and I share with them what that has been, might have you give it another thought. And the other thing I share with them is that, the other side of the coin is that because of that skepticism, the clinical trials that are being conducted on medications that you need don't tend to have a whole bunch of folk of color like tripping over themselves to be in these clinical trials. And so the data that we have and the side effect profiles and everything is really based on a whole population of people that essentially may be left out. And I encourage them to consider using GeneSight because it will consider their specific metabolism and how their body might metabolize different medications differently just based on being a totally different population. And I also let them know that GeneSight destroys, the samples, so they don't have to worry about, it getting used for something else. And the example that I give them to reassure them, I've been on this journey now for almost 10 years, I think. And in the beginning, some medications that are used in psychiatry weren't being, they weren't being paneled on GeneSight. So once those medications were, that whole class of medication was included on the GeneSight panel, then they would have to send in another swab. I mean, I just couldn't go back and say, can you go back 5 years and get that sample from Miss Jones and run it, for antiemetic medications, because we use those for mood stabilizers in psychiatry, and that gave them reassurance. And I could talk forever. I don't want to take up all of the time because I have so many examples of what I have to do to encourage the population that I care for to consider GeneSight or any genetic testing to help them, have more tools in the toolbox so they can get better.
Thank you so much, Dr. Shannon. I really appreciate that perspective. Dr. Alva, do you have anything to add, or how do you discuss with your patients about GeneSight's testing privacy?
Yeah, most assuredly I do. I definitely wanted to echo what Dr. Shannon just made mention of. Being authentic and being as open with people is ultimately what's going to drive the bus. So letting people know and treating them as we would want to be treated is probably the best policy, right? The golden rule does apply. Treat others the way that you would want to be treated, which means that people need to be educated about the pros, the cons, the alternatives associated with. And let's be frank, GeneSight or Myriad's test is not the only genetic assay that's out there, but it is the easiest, the most user-friendly. It's a multi-combinatorial approach, which means it's most methodical, and it's probably one of the assays that's been most extensively studied. And obviously, the largest pharmacogenomic study that's been done to date was done with this. So there's a lot of validity associated with its utilization. And I would certainly echo what Dr. Shannon just made mention of. We're all made up a little bit different. Our phenotype, what we see outside, doesn't necessarily reflect what we have inside, our genetic makeup, right? And that's why there's, the beauty of diversity is the fact that we're all a bit different. But it's kind of nice to be able to clue in as to subtleties that we carry based on the gifts that mom and dad gave us that help us process medications, that allow us a glimpse as to how different medicines might interact with our makeup. And so that's very important. And, akin to Dr. Shannon, and I'm sure that, when we hear from Dr. Ranchero, I've been involved with investigational research work for over 27 years. And one of the things that I've always espoused is, again, the representation of different ethnic groups, right? I mean, look, I was born in Mexico City. My father is French and mother Mexican. So talk about a cross-cultural approach, right? Where I grew up, obviously steeped with different points of view also and different perspectives. So it's always important to include as many people as possible. And that's one of the beauties associated with, having a test like this and having a company like Myriad to be able to espouse and champion, a tool that, by the way, is not an end all be all. And that's a very important thing. A genetic assay like this is not going to tell us what to do. It's an aid. It's like a great additional tool that we have in our tool belt to figure out what the best fit is for our patient and to be more methodical and precise about how we first approximate a patient and then what next steps to follow.
Thank you so much, Dr. Alva. I really appreciate you for sharing. Dr. Ranchero, do you have anything to add to how you discuss GeneSight privacy with your patient?
Yeah, one thing, just reassuring the patient, this is not 23andMe, this is not Ancestry.com, this is private, this is HIPAA, this is confidential, and it will not be shared. And have I had patients who tell me, hey, I found a daughter in California, and this is not going to happen. And letting the patient know that this has been vetted and this has been researched, and that I trust it, and building that relationship with the patient and letting them know this has been vetted by our system, this has been vetted by me and others. And so it's been tested and it's evidence-based.
Thank you so much. And so still with you, Dr. Ranchero. So how exactly do you actually reduce some patient concerns about privacy? So you explain GeneSight to them, but how does the conversation continue, or how do you actually help reduce their concerns?
I think you have to take a step back and say, how are you building that relationship with that patient? Being in primary care, I am very preventative. And one of the things that, I tackle day in and day out is cardiovascular disease, obesity, diabetes. But I know this, if a patient has a mood disorder, personality disorder, or something that needs to be addressed before I can deal with the physical, then I have to go there first. And it's also meeting the patients where they are, meeting the patients that, what brought them into the office. What is it about their mood, using motivational interviewing to say, what is it about your depression? What is it about your anxiety? What is it about your mood disorder that troubles you, that prevents you from living the life that you want to live? And letting the patient know that I'm here, I'm their guide, I'm their consultant, I'm their expert, but ultimately letting them know that they are autonomous individuals and doing shared decision making, and letting them say, hey, this is what's out there. And also letting them know, hey, it's 2023. We've advanced, and we need to recognize that there are differences genetically, there are differences in our DNA, even between siblings. And also recognizing that we can't treat everyone the same, but we can treat people fairly, and we can treat people with evidence-based medicine. So to help them to live the life they want to live, I tell my patients that, hey, you know what? I want you to live a long time, but more importantly, I want you to have the best quality of life. And if your mood, your anxiety, your depression, those things are getting in the way of your quality of life, then what would you like to do about it? And here are the tools, here are the options. And this is, if you'd like to, asking the patient, would you like to hear what has worked for some of my patients, and letting them have the onus to research it, to look it up. And also letting the patient know that, what is it? What can we work on first? Yes, I'd like to work on your blood pressure. Of course, I want to work on your blood sugars. Yes, I'd like to work on your weight. But if it means first, I need to say, hey, you're worthy of good health, maybe that's where I need to start. And so oftentimes it's building that relationship, and it can be, especially in primary care, an intergenerational relationship where, you know what, I know about your family history. I know about your mom. I know about your dad. I know about your uncles. I know about your children and what's going on. And building that trust relationship from the very beginning. And then also letting that patient know, especially if it's a new patient, what is it that I should know about you and your health, your culture, your faith, if you have faith, your values, your beliefs, what's important to you, what are your healthcare goals? And at the end of the visit, I'll always ask them in bringing the trust together, especially if it's a new patient, what would you like to know about me? What would you like to know about my practice or my team? And you can ask whatever you want to ask. And, you know, being human and connecting with that person.
Thank you so much, Dr. Ranchero. Dr. Alva, do you have a similar perspective, Dr. Ranchero, about prioritizing the patient's quality of life as far as having a discussion about reducing the patient's concern about privacy?
Absolutely. Dr. Ranchero, I mean, speaks some serious wisdom right there, right? And, you know, I love that analogy. I utilize it all the time. It's like, you know what, anybody can drive a plane or, you know, drive a boat up in the air or in the middle of the ocean, but actually, you know, anchoring or mooring and, you know, parking or getting out of the harbor, that's a difficult thing. You know, taking off, landing, that's a difficult thing. And that's where, you know, as clinicians, we want our patients to know, look, I'm co-navigating with you. I'll take care of those pieces. But you know what? I want you in the driver's seat handling all of the other things, right? And, you know, as Dr. Ranchero made mention right now, I love his perspective. It's really nice because, you know, when you utilize motivational interviewing, you'll definitely get to the root of whatever concerns people have. And so as we initiated, I think that regardless of what your outward appearance is, you're due respect. You're due, again, an authentic experience with someone else, another human being that ultimately is trying to guide you down the path that if you already knew it, you wouldn't need to resort to that professional, right? So long as, you know, there's a bit of humility that's built in that we bring to the table also, that's really important. And, you know, again, in tying it back with this genotyping assay, I made mention, you know, this is not an end all be all, but it is a phenomenal ancillary tool to help us be better clinicians. And so letting people know that we're not omnipotent, we don't have, you know, again, every possible, you know, solution, but we can, through the appropriate application of scientific principle, actually get people a lot better, a lot quicker. And that's exactly the way that I view an assay like this, right? And humanizing things to patients is really important. They come in and they're fearful, you know, regardless of the backdrop of the individual, and more so marginalized groups that may not have felt like they were being heard up to this point, right? And ultimately, what we're talking about is, you know, true equity, where people feel like they're being heard, they're being treated with respect, they're being treated in a humane manner, right? So in a nutshell, I agree with what Dr. Ranchero was saying.
Thank you so much, Dr. Alva. And I do want to just reiterate that just GeneSight or Myriad Genetics privacy policies, we do destroy all genetic information after 60 days or earlier upon request. And also, we do not sell the patient's genetic information as well. That was a really important question from the audience we want to address again. And so the next question, and thank you so much, you all, for sharing so much wisdom, is for Dr. Shannon. So how has your personal experience helped in treating the mental health of patients of color? And is representation important for you, for your patients of color? Dr. Shannon?
It is extremely important. So important that I work in a system where a lot of my colleagues would not choose to work if they had other options, which I do. But I think that the least of thou, the disenfranchised, the what I call my gap patients, which is the reason why I opened up the clinic at my church, because it was a misperception that when, you know, Obamacare came about, it was going to take care of everybody. But I kind of think kind of sideways, and you kind of have to do that as a psychiatrist. And I said, well, if that's the party line and that's what everybody is thinking, well, how does my patient who is not my patient that lives up under the bridge, did he get the memo? Because he doesn't have a radio, he doesn't have a phone, he doesn't have a fax machine, he doesn't have anything to even know what that is. So I wanted to be the gap person, or have our facility be in the gap for those people who had to make a choice between eating and paying for insurance. And if you have to feed your kids, you're going to choose your kids and not the insurance. And for the, the other persons who were covered. And GeneSight just came in and helped me to be able to provide my free service and offer them a chance at getting their medications correct, because I was practicing also under that kind of an umbrella, so that I wouldn't have to do the cookie cutter kind of medicine, just knight everybody and write a prescription and just go on about your business. And the state hospital really provided me an opportunity to help some very sick people, but also get a chance to learn more about this tool that I didn't have in my toolbox, and presented such a convincing story that my state did authorize use of it before it was, made available for people who are on, Medicaid, Medicare, and at a reduced cost. They made it available because I've advocated for my patients so fervently, because I kept running into situations where clinicians who really don't know about African American or any person of color having different metabolisms. And I would walk into these settings where the bigger, the blacker, and especially if they were male, they were on horrendous doses of long-acting injectables, mood stabilizers, and it was really making me two things, very, very sad, but also very aggravated, because unfortunately, I knew about this because I attended conferences that were geared towards telling you about how, Native Americans metabolize medications and alcohol differently. And African Americans may not have this enzyme or may have too much of that enzyme, and that actually typical wisdom of giving them more antipsychotic medication really goes against how their bodies metabolize. And then I would have to come in and gingerly, kind of tell a colleague, or, by asking a question instead of saying, what in the world are you doing? Have you thought about this? And then introducing them to GeneSight and saying, it's really not as, I'm not oversimplifying the situation with green light, red light, yellow light, but it helps the patient to kind of put it into perspective. And the one thing I want to make sure I say, kind of piggybacking on both of my panelists' previous comments on it not being a one-stop shop, but it's a wonderful tool. But I've even had patients ask me, well, if this printout is telling you what medicine to prescribe for me, then why do I need you? And I simply and humbly say to them, this paper doesn't have 36 years of clinical experience, and I do. And so when I put that power with this power and erase your fears and concerns about what's going to happen after, we get the information, then you can be well on your way to a healthy life, a healthier life, and a greater quality of life. And if you look at, common TV now, when people can prove something, they say, I got receipts. Well, I have receipts, but I just can't tell you whose name is on the receipt because of HIPAA. But I have stories of people who have spent 15 years in and out of hospitals. And then between my bosses, GeneSight, and the trust of the patient, a patient who had been inpatient more than out for the past 15 years, miraculously and thankfully had 3 years not being in a hospital or a jail. And once that happened for that patient, it just gave me the courage to do more advocacy for other patients. And then GeneSight, Myriad did their part in working on the financial structure so that more patients, could avail themselves of this service.
And thank you so much, Dr. Shannon. And for those of you who don't know, so Dr. Shannon also had provided a lot of leadership and guidance to our sub-analysis of our guided results that focus on Black and Hispanic patients versus overall results, because she's so passionate about people of color. And so we're really thankful for you for that as well, pulling out those results for us. I do want to go to Dr. Ranchero about his personal experiences and how has his personal experiences helped in treating the mental health of patients of color for Dr. Ranchero.
I think, as Dr. Alva mentioned earlier, being authentic and real, and even at times sharing a little bit of your own life experience. But one of the things that I've really used the GeneSight for is I have a large LGBTQ plus population. We do see a lot of unfortunate mood disorders in that population, and I'm being much more preventative in saying one of the tests that I like to show is, hey, you are producing enough of the neurotransmitters, or hey, look, the MTHFR gene, you inherited a mutation from one of your parents or both your parents. And sometimes it's especially in primary care, there is, especially among minority populations and disenfranchised and people of color, there's a distrust with government, especially after the pandemic. And a lot of my patients, no, I don't want anything that's going to modulate my neurotransmitters. And what can I do instead with supplementation? And then it's also educating the patient on, it's taking away the stigma of mental health and saying, hey, these are neurotransmitters. And for some reason, your genetics, your genes were activated, for depression, for anxiety, for different things. And it's a disease and it's treatable, and that there's hope. I think that's a big thing. And also letting patients know that some of these conditions are very chronic and lifelong, and taking away that stigma and realization that you don't have to be this super person. You don't have to be a super mom with a job and kids and be a super wife and do all these things. That asking for help is not a weakness, that's actually a strength. And I think for a lot of people, especially in the rural communities where I practice, letting them know that, hey, this is a safe place and we care about you. And this is a safe place, and I'm glad you found our clinic, and you are worthy of good health, you're worthy of good medicine, and you're worthy of good care and worthy of love. I think a lot of times people don't see themselves worthy of these medicines and having a good life. They're stuck in their misery. And again, being a primary care and preventative medicine doctor, I know that there's such strong correlations between a person's mental health, their mood, and their physical health. One of the hats that I wear is a consultant for large corporations because they're tired of seeing their employees, their productivity go down while they're paying more and more to insurances. And a big part of that is, can we be doing things differently and doing things more preventatively? Why do I need to wait and try different, 3 or 4 different antidepressants, and it's been a year's time, and that person has gone on suffering? Can I maybe get it right the first time or the second time, or say to them, hey, listen, you are unique. And you know what? These genetics, this is how the medicines affect your body, and this is how your body affects the medicines. And we're all different. And I have no problem saying this is you, and no one else is like you. And that we can make decisions together, again, that shared decision making, and say, what do you think about these medicines? When I was taught, everyone was put on an SSRI to begin with and follow up in 6 weeks. And then, okay, increase the dose or change it. And then follow up another 6 weeks. And then how many patients have we lost because they can't tolerate it, or because it wasn't effective, or because they had a bad side effect, or, you know what? And then once again, the healthcare community has let this patient down. And so oftentimes letting them know, the reason I want to do this test is that you're worth this test, whatever it costs, and that it's going to give us information that's going to help us as a team make better decisions, with them being the ultimate decision maker on their healthcare.
Thank you so much, Dr. Ranchero. And Dr. Alva, so how does your personal experience help in treating patients with mental health conditions, those patients with color, and also is representation important for you and your patients?
Oh yeah, it's easy to follow with the eloquence that Dr. Ranchero and Dr. Shannon bring to the table, because when you speak about concepts like pharmacokinetics and pharmacodynamics, it's so easy to go over people's heads. And our role is to help simplify language, to help simplify terminology, and to help people really have a better grasp and understanding of what's going on. Part of the reason by which there's distrust is that sometimes people feel like they're being talked down to, when in reality, again, we should have this dialogue where, Dr. Ranchero made mention, a shared decision-making process is critical. But the only way to be able to do that is by making sure that people comprehend the material that is being laid out before them. Dr. Shannon made mention of being better clinicians. Well, that's a phenomenal example of what this, the largest pharmacogenomic study that's been done has been done by the folks from Myriad. And when you take a look at that, you're taking a look at 2 groups, treatment as usual, what we've always done, versus treatment as usual, plus the guidance associated with the results of an assay like GeneSight. And when you take a look at specific groups, like for example, those individuals that have gene-drug interactions, where it might be important to take a look at cluing in what might be a better fit for that person, that's where all of that, discussion, and truly a beautiful illustration that Dr. Ranchero laid out of making sure that people feel like they are being seen in a unique setting, right? That we are speaking to them. It's one individual. It's not, just everybody, right? And speaking about the fact that, thank God for the fact that there is diversity and that we are different. Imagine what a dull world this would be if everybody were exactly the same, right? But we're not. And that then means that we need to speak towards the virtue associated with our differences, but also, acknowledge that if somebody has concerns, has fears, has trepidations, has concerns, has worries, has questions, well, let me clarify those, right? And that we do so in a manner where it's understandable, it's digestible, it's actionable. Because it's one thing to say something that's ambiguous and amorphous and doesn't really hold much weight, but when you lay things out in such a way that people comprehend, hey, here's this report. Dr. Shannon made mention, it might seem a little cookie cutterish or a little too simple, too mundane to simply say, it's like a traffic light, green, yellow, red. Well, it's not quite that simple, right? Because I mean,
Right.
you can certainly get a lot of juice out of a red item drug, right? So long as you understand the clinical significance associated with why it is categorized in such a manner. And Dr. Ranchero made mention of a trimonoamine modulator, like uh, you know, methylfolate. But people don't understand that, right? And they don't understand the difference between, oh, well, what's the difference between folic acid and L-methylfolate? Well, there's a significant difference, right? And it turns out that if genetically you're prone towards having a deficiency in its production, then maybe having some type of a supplementation that's considered not necessarily a drug, but a medicinal food would make sense, right? And so even concepts that may seem, arcane or odd or weird or, too out there can be, brought to the forefront and, made simple, but in a respectful manner, right? So I think that that's been part of the issue in the past. Dr. Shannon made mention, she was at a clinic where people were being viewed, and the bigger and the blacker, as you made mention, maybe the scarier for the other people that were like perceiving them, over medicating made sense in that setting. Well, that's a wrong thing to do, because it turns out that that individual, being a poor metabolizer and having had, again, a genetic makeup where you're actually lacking the specific genes that code for a particular gene, right? All of a sudden, it's like they're not going to need as much. So
And
having that knowledge is so important right off the bat.
Thank you so much, Dr.
and I
Alva. Dr. Shannon, did you have anything to add to that?
I did. I can tell you in those settings where they were being over medicated, it was like an awakening when I would suggest, go against the conventional wisdom and lower the medication, because maybe they're tearing up the place, like literally, because it's akathisia and it's restlessness. Turn it down, let's just try it and see. And then they're amazed. And then I introduce them to GeneSight. And I want to go back to a very strong point that Dr. Ranchero made, that I've had to use recently, because I treat everybody from age 3 to 103. And so recently there was a supply chain issue as it pertained to stimulants. And of course, insurance company, they're asking us to prescribe a medication that is going to give the worst side effect profile. And even though it may help them to, focus in school, how long do you think they're going to take it if it's tearing up their stomachs, if it's, doing other things that a parent isn't going to stand for? And I've actually had to use the panel to get a prior authorization pushed through. I say, so you're telling me to prescribe this to our patient, because it's our patient, we share them. I'm trying to do the best for them. Are you, if you are going to pay attention to this data that I have? Because I'm telling you, I'm not willing to take this 8-year-old through 4 bad medications to get to the good medication that I know is going to help them. And so what are we going to do? And when you ask like that, and the parent is on the phone too, the parent says, well, what are you going to do? And so then they get the medication that is helpful for them. And it changed this particular kid's life, because it was a situation where, well, to have ADHD anyway, it can't just be in one setting, meaning it just can't be that they're having problems at school. It has to be in more than one setting. And this particular individual because of their impulsivity and hyperactivity, they were beginning to be a danger to their other siblings. So it was gonna, if something didn't happen quickly, I was fearful that the kid would be removed from his home, and all because an insurance carrier just refused to pay for the medication that we already knew would work, because he had to get that particular medication when the supply chain issue of the bad stuff. I mean, I don't want, and I'm not calling the name of that medicine, so I'm not, slandering or, throwing mud, but he was able to get that medication for 1 month. But then when the supply chain issue, was resolved, they were like, okay, we'll put him back on that other stuff. You mean the stuff that had him sick all the time? I'm just not going to be able to do that in good conscience, good ethics. So use the GeneSight to kind of back me up. And they finally did a prior authorization. I'm so happy the kid is doing marvelously, and so is the family.
Awesome. And Dr. Shannon, can you expound a little bit on the procedures with prior authorizations for people that haven't done one before? How's it
We
been
don't
for
have
you?
enough time on this podcast to go through that arduous task. But that is the other reason too, why I developed the my free clinic, so that I would have time to do these prior authorization things, because they are very time consuming. And you might as well go ahead and go find a playground and get on a merry-go-round. That might get you to the authorization quicker than, because you'll call the number that you've been given to call. But then that person, lets you give your spiel, your advocacy, talk to them. And then they say, oh, I'm sorry, that has to go to over here. And then you call that number and pray that somebody answers. And then, then they tell you, well, we're going to pass this along to the right team, and then they're going to call you back. And then, but in between time, you still have things to do and patients to care for. So it's a very time consuming task that a lot of doctors, especially if they are a part of a big practice where they have somebody designated to do that, they're not going to do it. GeneSight for me kind of squashed simplified the task for me, because then I could just say, well, let me fax this to you, or call me so I can, tell you more about this. And it was just very helpful in streamlining that very long, oftentimes. I've never had a short prior authorization experience. I don't know about the rest of the panelists.
Okay. And yeah, maybe other panelists can speak to there. Like, does GeneSight make the prior authorization process a bit easier, or maybe Dr. Ranchero can chime in now?
I think that it's going back to, again, what is your health worth to you? And then just pausing. What is it? And sometimes it's getting to the end of the visit, or even the beginning of the visit, because I'm primary care, and saying, Mrs. Smith, if I could help you with one thing today, what would it be? And then just being quiet and see what comes out. It's my back pain. Not usually come out, it's my anxiety. It's my depression. It's my lack of motivation. It's, things come out, and, and sometimes I just like I tell my patients, I'm going to check your liver, I'm going to check your kidney, I'm going to check your thyroid. I might even check some of your vitamin levels. I'm going to check your cholesterol. And so would you mind if I GeneSight tested you today? If your insurance doesn't pay, I believe it's $300 or $330 that they'll get charged. Is it worth it? And letting the patient know, yes, I believe that cost is worth it. That way we can make educated decisions together of what we're going to do. I can tell you right now, a CBC, if I run it through the hospital system, it's probably $100, $200. If I run a complete metabolic panel, I mean, by the time I'm done running all the tests for their annual physical exam, it's over $1,000, unless they're going to a lab, on the side. And that's just the way it is. And sometimes letting patients know that this is your deductible, and this is what it's going to cost, the most it's going to cost. And letting the patients know that, I had a few patients decline it. Yes. And then realizing, and then ask him, well, what is it about the cost that bothers you? And then addressing those, those concerns. Yes, $300 is a lot of money for some people. The great news, especially for Medicare and Medicaid, it's covered. So my people that are my patients that are socioeconomically maybe not at the highest levels, well, at least we can do something about it and get them on the right medicine, or get us in the right direction, on the right path, to help them towards healing and wholeness, so that we can work on some of the other things that they come in. They're not worried about necessarily their blood pressure that's 200 over 100, but I am. They're not worried about their blood sugars. I am. They're not worried about their weight. I am. They're not worried about their cholesterol. I am. But I also know that the door to those things is, how am I going to address their inner struggles? How am I going to address their motivation? How am I going to address their mood symptoms? I have to address those first, because I know even addressing some of those things, we see the studies, you improve people's mood and depression and anxiety, their A1C improves. Whoa, their blood pressure improves. Wow, their weight improves. My goodness. And it's realizing that we're connected. We just can't compartmentalize the physical part of our life with our psychological, emotional, spiritual component. And sometimes addressing those things, we do see the biggest, if you will, bang for the buck.
Thank you so much, Dr. Ranchero. And Dr. Alva, your experience with prior authorizations with GeneSight?
Beautifully said. Pithy, right? Excellent. I mean, succinct, to the point. But I would add a couple of additional things. Just as Dr. Ranchero made mention, how are you supposed to know that somebody's red blood cell count is low unless you check for it? That their thyroid's not working well unless you check for it? That their vitamin D or B levels are low unless you check for those? And, when you talk about a test that won't need to be replicated, because let's face it, your genetic makeup is what it is. It's kind of a savings then, right? It's like, what? I only have to do this once? Yeah, that's right. And, I like that Dr. Ranchero makes, throws out the sticker shock. You might be on the hook for as much as $330, but the majority of people pay less than that, right? But at least that way, you're already setting the standard towards its highest for people that are insured. And for the most part, there might be some supplementation that's needed. A lot of our patients are Medicaid and Medicare recipients, and it's basically covered. So that's pretty cool. I think your question, though, was earmarked along the lines of getting a prior authorization of a medicine that we want to step in with right away, and then having at least some value tied in with, look, this is a scientific assay that supports that this might be the best fit for the patient, rather than losing time, losing resources, losing, a lot of emotional and physical discomfort. It's like, why don't we just go straight over to, what should be working? And look, here's the rationale associated with it. That has been helpful, but it's not always helpful, because as you're well aware, insurance companies oftentimes want to negate something because they feel like, they want to be penny wise but pound foolish. They'd rather look at the tree instead of stare at the forest that is before them, and at least understand that if somebody's better, they're not necessarily showing up to work and just sitting there but not being productive, right? So that presenteeism and even the absenteeism, when people just don't show up, will go away if we're helping them out. Dr. Ranchero made mention, pain becomes less exquisite. The immune system actually kicks up when people have, a resolution of their underlying affective symptoms. So, everything's tethered together. And if we're able to get people better faster, geez, that's like a slam dunk.
Thank you so much, Dr. Alva. And we're almost at the end of our time, but we do have one more important question from the audience that I hope that all the panelists can answer. And starting with you, Dr. Alva. So someone asked, how do you communicate with prescribers who say that genetic testing or GeneSight doesn't work?
Well, I educate them that it is a tool, right? And it is not an end all be all, but it is part of the process of what we do. Dr. Shannon illustrated it beautifully. It's like part of the art and science of medicine is that we're bringing in all of the elements at our disposal to come up with the best decision. And so I will typically say, well, what is it that, because a lot of people feel like genotyping is not ready for prime time. Well, I would disagree with that. I would disagree because, when you take a look at, the cytochrome P450 isoenzyme pathway and you take a look at pharmacokinetic issues, there's a lot of validity with knowing whether somebody's a poor metabolizer, an extensive metabolizer, an intermediate metabolizer. And pharmacodynamically, it's kind of nice to know, hey, should I avoid certain medicines because of serious cutaneous drug eruptions like Stevens-Johnson? Well, yeah, right. But, people just don't get that. And we've seen a lot of literature in the past about people that are carriers of the short, allele of the serotonin transporter. And you know what? Those are people that are more prone towards being treatment resistant or maybe even more prone towards suicidality. And if given the wrong medicine, that's going to expose them to additional problems, So why not just shortcut in the right way and get to where you need to be?
Thank you so much. And Dr. Shannon, what would you tell a prescriber that doesn't think genetic testing or GeneSight actually works?
I give them all of the examples that I wasn't able to share. I only shared 2, but the success stories that I would share with them, usually after they hear all of those, they're convinced and they're on board. And I just caution them, don't say that it's going to, fix everything, but it is a tool, and it's a very effective tool if you're really interested in wellness and not in a buck. And
Well
when
said.
you meet them with their conviction, are you really here to heal? Like I hear Dr. Ranchero, you sure you don't want to come over to the psych realm?
I thought about it in residency, and I was and then I did some inpatient psych, and I said and I'm glad that we can be more preventative in the psychiatry realm now. That's where I use GeneSight.
And I like that. I meant to mention something about you saying that. I happen to be one of the psychiatrists who does not sprinkle medicine on everything that walks in the door. And I've had, some shocked, looks from patients who didn't get their medications changed. I was like, well, why would I change it? You say everything is great. If it ain't broke, don't fix it,
Yeah.
And if you're doing well, let's keep it that way. So
That's wise.
Yeah. For
GeneSight
me,
helps in that
yes.
regard.
Sometimes it also gets into the buy-in for the patient, and I'll tell the clinician that. Why does Dr. Alva do double-blind placebo-controlled studies? Because we know placebo is powerful, and we also know the expectation effect that if that patient has a trusting relationship with that clinician, that's even more powerful. Oh wait, Dr. Ranchero gave me a Tic Tac. Well, you don't know that. I just said it's an expensive Tic Tac and it's going to help you. And if you believe it's going to be expensive, it's going to help you even more. And so we have all these things. I know we don't use placebo, but at the same time, if I can get that patient believing that this medicine is going to help them, believing and setting correct expectations, it's going to take 2, 3, 4 weeks, or maybe
That's right.
you need something sooner. Okay, I get it. But at the same time, it's saying, hey, I'm doing this test because I want to make sure that I'm treating you right and treating you what you're worthy of and giving you the right thing. I'm not going to just not throw something at you. And then just like any chronic disease, saying, hey, there's lifestyle modifications you need to make, and there's other things you need to do. And this is, that your mental health is worth it. And this test is going to help us make a better decision for that patient. And in being preventative. I mean, yes, there are times, of course, I'm going to have to refer a lot of patients to Dr. Shannon, but if I can catch them early enough, then we can do it in a way that is preventing potential for catastrophic medical experiences. I don't want, letting that patient know, I don't want them to be hospitalized. I don't want them to lose their job. I don't want them to lose their family. But we can do something about it sooner and recognizing it sooner. And if you will, tailoring and targeting and focusing where we need to focus.
And before we go, I just really want to thank my fellow panelists for the work that you're doing in this area. We're kind of preaching to the choir. I wish that my patients who think that they don't have a voice could be here so that they could know that there are voices speaking on their behalf. And I'm so grateful that I've refined my punch a little bit since I first spoke with John Michael. I was furious. And I'm so glad he listened, and then Myriad came behind and just jumped on, just tried to do more and more to help these patients who, like Dr. Ranchero said, are worthy. They deserve good health, good physical and mental wellness. Because some of these psychiatric medications, as you know, they can, lead to poor health outcomes too. And it's like you said, I've never seen a body walking around without a head, or a head walking around without a body. They work in concert. And if there's a disease in one, it's going to affect the other. And GeneSight and panelists like you do a whole lot to try to help minimize that. And I'm grateful for the population that I serve.
Thank you, Dr. Shannon.
Yes, thank you so much. And thank you to all the panelists, everyone that attended today. We did get to your questions today. We'll definitely follow up after this webinar. And if you have additional questions, please reach out to us. And we did record this session, so we'll be on our YouTube channel. I'm so grateful to be able to moderate this talk, and I'm looking forward to the changes in patient care that happens after this GeneSight Cares. Thank you so much, all. Have a nice evening.
Thank you.
Thank
Bye-bye.
you. Take care.
Bye.